Welcome, everybody, to another episode of Dr. Matt, Dr. Mike's Medical Podcast. Matty, how are you today?
I'm well. Should we tell the listeners that we've got a new audio setup?
I'm worried that if we do that, we are we're setting ourselves up for failure because hopefully this recording sounds better than others.
Hopefully it sounds awesome.
Yeah, well,
and it's like you're not even listening to us.
We'll get better.
All right, so we've got a complete new setup, both a mixer, which I can see all the dials going up and down, which looks like mine's at a good range.
Yeah, everyone's loving this conversation about behind the scenes.
And we've gotten rid of our old microphones.
Yes, we have.
So what are we talking about today, Mike?
We are talking about NSAIDs.
What did N say?
Who's N?
That's my question.
Who's on first?
All right, so NSAID's acronym?
It's an acronym.
Standing
not
for...
an initialism like FBI, but an acronym like SCUBA.
So that I'm not going to ask what an acronym is then.
Okay.
So NSAID stands for non-steroid anti-inflammatory drugs.
Yes.
Drugs.
Drugs.
So NSAIDs.
Yeah.
Okay, so do you want to tell the listeners what this actually means?
Okay, so non-steroidal. So it's not working as a steroid, which means that the way these drugs work in the body is they don't jump through the fatty layer of the cells to play around with the DNA inside. It works by binding to particular receptors.
Okay. So these are like, steroids are like glucocorticoids that we can release ourselves under stressful situations to help reduce our inflammatory response.
Yes.
But these are non-steroid.
Yes.
So they're non-lipid soluble. So they have to do their action by binding to things on the outside of a cell. Is that right?
That's right. And they're not inflammatory. They're non-inflammatory.
Okay,
anti-inflammatory is the term that we use.
So the anti-inflammatory, they're a category of drugs. How many are we talking here, like in the category?
Of NSAIDs?
Of NSAIDs.
I don't know.
Give me a number.
Heaps.
Okay, I think there's between 20 and 50.
Okay, yeah.
But we're not going to go through that many, are we?
I hope not, and the listeners hope not. We'll probably go through about half a dozen.
All right, so maybe we'll get started with telling the listeners why would you want to use non-steroid or NSAIDs?
Okay, so predominantly people use NSAIDs for three main reasons, but there's other reasons that people use them, which we'll get to. But mainly it's to stop inflammation, stop pain, and stop fever.
Right. So when we talk about pain, we did this last week when we spoke about opioids. And we found that opioids particularly are useful centrally, so in the spinal cord and probably the brain, to get rid of pain, right? Is it fair by assuming that the primary action of NSAIDs work more peripherally, so more at the site of inflammation?
More at the site of inflammation, yep, so peripherally, and a little bit at the spinal cord as well.
Okay, and would you assume, this is maybe a long stretch to assume this, but is it fair to say that a lot of pain would come from inflammation? At least acutely?
Yes. So I would say acute pain, not chronic pain, not neuropathic pain, but acute pain would be nociceptive, meaning stimulation of pain fibers. And one of the most common ways that you can stimulate pain fibers is by releasing chemicals that actually bind directly to them to stimulate them or drop their threshold down to make it easier for them to send a signal.
Yeah. So I think pain's obviously there to notify us that there's been injury.
Yeah.
There's been damage.
Or potential.
And what goes hand in hand with tissue injury will be inflammation, which we have done that previously. So something wrapped up in the inflammatory process will induce a painful stimulus.
Correct.
Now, do you want to talk about what that may be?
Yeah, I think it's important to say that during the process of inflammation, you get those...
So give me an example.
Of an inflammatory response?
Yeah, so I might get pain from a form of inflammation.
Okay, I punch Matt in the face. So
that's a mechanical?
That's a mechanical force or trauma damaging his vascularized tissue...
On my face.
Of his big head. And this leads to an inflammatory response, which is basically a whole bunch of cells spilling their guts, which are filled with chemicals.
Okay.
And look, there's hundreds of these pro-inflammatory chemicals, but one of the very important types of chemicals is something called prostaglandins.
Right. And so these are playing a role in what? Sensitizing the nerve?
Yeah, so basically prostaglandins, what they'll do is they drop the threshold of a pain receptor, so a nociceptor. So remember that pain receptors, they need to have enough positive charge inside that it's around about negative 55 millivolts. This is the key that unlocks all the sodium channels that results in sending the painful stimulus, also known as an action potential. So you can change around with this threshold and you can make it closer to the threshold. Usually it rests at negative 90 and needs to get to negative 55. But you can, with the release of prostaglandins, you can make it rest at like negative 70, negative 60. So it doesn't take much of a stimulus
To then make it
to trigger
higher.
the pain signal.
Okay, so predominantly NSAIDs will work in the space of stopping prostaglandins making pain, or does they actually stop the production of prostaglandins?
So it stops the production of prostaglandins. And important to say that prostaglandins, they don't just play a role in pain, but when you release prostaglandins, you also have a multitude of vascular effects, which basically go hand in hand with inflammation. So vasodilation and increased vascular permeability. These are also mediated by prostaglandins.
Yeah, and I think we'll also just note, because you did say that NSAIDs primarily work by doing three things: pain, inflammation, but also fever. And one primary chemical that's released in tissue injury, particularly through infection, is something called interleukin, which usually comes from something like, say, a macrophage. And if you put this chemical into your blood, it will circulate and go up to your hypothalamus. What do you know the hypothalamus is important for? Many
Heaps of things, but one is it's the thermostat of the body.
So the temperature. And so in this case, it will change the thermostat to a higher temperature, which will basically tell your body you're cold, and you start to shiver and want to put more clothes on. So this is a fever.
And it raises that temperature up, and you end up feeling like you're closer to 39 degrees Celsius.
And so
40 degrees.
NSAIDs can block fever production. So this is what an antipyretic...
So through interleukins or through prostaglandins?
I think it's through the prostaglandin intrinsically in the hypothalamus.
Yeah.
Through maybe the intrinsic blood flow in the hypothalamus, but I could be wrong.
Yep.
But it will block that effect.
So blocks pain by stopping the sensitization of pain fibers by prostaglandins.
I think also, just to add a bit of detail there, also downstream effects of bradykinin as well, because bradykinin is a sensitizer to nerves.
It stops the inflammatory response, or at least certain aspects of the inflammatory response mediated by prostaglandins, and also stops the fever response mediated by prostaglandins. So as you can see, prostaglandins play a very important role in pain, fever, and inflammation, but they also play a multitude of other roles throughout the body.
Okay, now before we get on to those, so why would a person use NSAIDs? Now, we'll get to the particulars a bit later, but you have the acute phases of injury. So this could be fractures, sprains, muscle injuries, so commonly in musculoskeletal, acutely, so that they're useful in that space. They also can be useful in some chronic musculoskeletal, so arthritis pain.
Yeah.
They're useful in there. They're also quite useful post-operatively, so after surgery, particularly, say, in dental surgery, they're good there. They can also be really useful in headaches, migraines, but also menstrual cramping.
So a multitude of...
So they're very widely used.
Yeah.
So how about we move now on to how do the prostaglandins come about?
Okay.
So I'm assuming this is the crux of where NSAIDs work. Is that fair?
Correct.
Okay. Do you want to start in that space?
So first thing I want to say is that you need to be aware that there's two enzymes. There's actually more, but we're only going to focus on two. Two enzymes in the body called cyclooxygenase 1 and cyclooxygenase 2. And they're two separate genes, right? And what these cyclooxygenase enzymes, or COX enzymes, do is that they produce prostaglandins. Now, they produce prostaglandins from something called arachidonic acid. Mm-hmm. And arachidonic acid is basically a breakdown product of cell membranes.
Yeah. What are they called?
Cell membranes, phospholipid bilayers.
Yeah. So just to add a bit of detail, sorry to jump in. So the membranes are made of phospholipids, and when there's injury, for some reason, there's an activation of an enzyme called phospholipase A2, which turns these phospholipids, which are the kind of fatty phosphate molecules into arachidonic acid. And so from there, we have to go from arachidonic acid into prostaglandins. And what did you say the enzymes are?
COX-1 and COX-2.
Okay.
There's a COX-3, but it's not worth bringing up.
I think it's also just important just to say here that COX-1 and COX-2 can also be called prostaglandin H synthase,
Okay.
1 and 2, but more commonly they're known. So technically they could be known as PGH2, 1, and PGH2, 2.
Great.
But more commonly they're referred as COX-1 and COX-2.
Yeah. So we'll just refer to them as COX-1, COX-2 in this particular podcast.
So once you've transferred this arachidonic acid with the help of either COX-1 and COX-2, what are you left with?
You're left with prostaglandins,
Yeah.
but it's not, not all prostaglandins are like one another. There's different subsets or categories of prostaglandins.
All right. So there's actually 5 of them. So I'm going to go through each 5, and this is what physiologically they do.
Okay.
Some are very important from a homeostatic point of view, and some can be there used in injury.
And so the prostaglandins, are they just prostaglandin 1 to 5?
Almost. So the first one, in no order, but this is the order I'm going to put it in.
So Matt's first one.
So there's prostaglandin D2.
All right.
So this will be called PGD2. Okay. Where do you find these predominantly? Well, mast cells will release this particular phospholipid, and it's important for recruiting T helper cells. So these are a type of white blood cell. So the mast cells are found in skin and in mucous membranes. So they're a good cell to tell the body when there's a problem going on, right? And so these mast cells release the PGD2 and recruit T helper cells as well as eosinophils and basophils into tissue.
All right. So all I hear is that this PGD2 is pro-inflammatory.
Yeah, and this particular step is really important.
Is it inducible or is it always active?
Well, seems to be important for allergic asthma.
Okay.
And so this particular prostaglandin...
type 2 hypersensitivity reactions.
Something in that space. Another action of PGD2 is in the brain. It seems to have a important function in regulating temperature during your sleeping.
Ah.
Okay. Another interesting function is it seems to be released to inhibit hair growth. And
Right.
so they've taken biopsies...
To inhibit hair growth.
That's right. They've taken biopsies from people who are bald, and their tissue in their baldness region, or their skin, seems to have higher amounts of this prostaglandin.
So wait, are you saying that by taking NSAIDs we've cured
I'm not saying
baldness?
anything.
Is that what you've said?
I'm not saying anything. Other functions of PGD2 is it seems to have a role in bronchoconstriction and also vasoconstriction. So that's
constriction.
constriction.
I thought the prostaglandins generally were vasodilators.
Well, they can be, and this is where we're going to get different.
Christ, okay.
Okay, moving to the next one. So this is PGE2. Okay, this one seems to be quite important in pregnancy. So this has a stimulating effect to activate smooth muscle, particularly in the uterus and the cervix. So this particular molecule, PGE2, can be used to induce labour. So
Yes, my wife had a prostaglandin gel used to hopefully stimulate little Tia to come through. Did not work. We had to jump on an oxytocin drip, which again stimulates the uterine contractions. And Bub luckily came about 30 hours later.
luckily.
Yeah, luckily.
All right, so this is important in labour and in pregnancy.
And it's in sperm, right?
I'm not sure. Well,
Yeah.
I guess that would play a role.
Prostaglandins in sperm, it plays one of the roles to irritate the cervix, which is one of the reasons why. So the cervix is all mucousy, and prostaglandins help break that mucus down to get the sperm all the way up.
Yeah, so
but
open the cervix up, right?
Open the cervix
Yeah.
up, but they also, how the people say, you're 40 weeks pregnant, you need bub to come, go have sex with your partner, and that's going to stimulate the process. The reasoning behind that, even though I don't think there's any evidence to say that it works, is that the prostaglandins in the sperm irritate the cervix enough to stimulate bub to come through.
And I'm guessing, I'm not saying this is true, I'm guessing that the prostate gland was named because it had prostaglandins
Yeah, it
from
releases
right?
prostaglandins, yep.
Which is possibly this.
Potentially prostaglandins are released from the prostate gland. So I would assume the prostate was named first.
That's what I meant.
Yeah,
Prostaglandin. Yes.
Yeah.
Right. Okay. So we've got, it's important in pregnancy and labour induction.
So we've only done 2, folks.
Yeah, I know. But we'll get there. But it'll make more sense to know this. It's also important for keeping the ductus arteriosus open.
The ductus arteriosus open.
Yeah. So
Patent.
It's a patent. That's right.
So what's the ductus arteriosus?
This in the baby that has not been born yet. So in utero.
Yep.
There's no need to send blood to the baby's lungs. Okay. Should we say fetus? Probably better. So in the fetus, in the uterus, there's no need to send blood to the fetus lungs to get oxygenation because the mother's doing it for you. So we divert, or the fetus diverts all the blood to bypass the lungs. And this is done by the ductus arteriosus.
From where to where?
From the pulmonary trunk to the aorta.
Oh, okay.
Now, this is kept open by PGE2. Okay.
Ah, okay.
So, from a clinical standpoint, if the baby is born, now it's a baby, neonate, if it's born with congenital heart defects.
Such as patent ductus arteriosus?
No, just other defects, probably like septal defects.
Oh, yeah.
Before they bring them into surgery to repair the defects, the physician may give PGE2 to keep the ductus arteriosus open.
To bub?
To bub.
Or to mum?
To bub.
Oh, okay.
Okay?
To keep it open.
To keep it open. And so we still get a decent amount of, I'm not sure the specifics around it, but it provides enough oxygenation for the baby until
so it stops significant
surgery.
Shunting and lack
Somehow.
of flow around the body.
But I will say this. In a patent ductus arteriosus, where you want it to be closed, they'll give an NSAID to stop.
Because it stops prostaglandins.
That's right.
All right.
And it will close it.
Okay.
I'm not sure if that confused everyone or not.
No. Well, it didn't confuse me.
Okay. So any other things here? Well, it also is a vasodilator.
I like all the questions you're asking yourself.
It's also a vasodilator.
Okay, so PGE2 vasodilates, PGD2 vasoconstricts.
Yes. Now, the use here, it can be injected, PGE2, as a gel into the urethra of the penis to induce erection. So,
really?
So males who have erection dysfunction may utilize PGE2 to get an erection.
Can I just ask a quick question? Why would anyone choose that over popping a little blue pill?
I'm not sure. Anyway, so that's PGE2. Moving on. PGF2, it's also important for inducing labour or also can be used in abortion. It seems to link through the oxytocin effect with PGF2, which then goes back to the corpus luteum.
So say that again?
So there seems to be a regulation between oxytocin, okay, this PGF2, and then this PGF2 goes back to the corpus luteum to turn it off. And if you turn that off, you don't have prostaglandin, you don't have prostaglandin, pregnancy ends.
So what would release the prostaglandins? Because I assume that this is an unwarranted termination.
So, yes.
Natural.
Yes. So if there was no fertilisation and there was no feedback, the PGF2 would then tell the corpus luteum to lyse or break.
Okay.
Yeah.
I didn't know that.
So this can be a medication for that case, but it also can be used for inducing labour as well.
Wow.
Okay, now we move into the other one. So now we go to thromboxane. So this is TXA2. So is
thromboxane a prostaglandin?
Well, it's in that pathway.
Okay.
But this one's called TXA2 instead of the PGs. So probably not, technically, the thromboxane. So this chemical, thromboxane, is produced in an activated platelet. So when platelets are turned on, it will release this to cause more platelets to aggregate and stick together.
So thromboxane is a procoagulant?
Correct. Or pro-thrombotic.
Pro-thrombotic. So it promotes clotting.
Yeah.
All right.
So I guess I could say here that it's also important. This is where aspirin will work, but we'll come back to that.
Okay.
Yeah?
Yep.
Interestingly, I found here we have something called Prim's metal angina.
I've heard of that.
Okay. It what
Is
happens?
it still called Prinzmetal angina?
Variant angina.
Okay.
So this type of angina is basically reducing blood flow to the heart. Mm-hmm. Okay, but this particular type of angina seems to be through vasospasm.
Yeah.
Okay. Now, thromboxane does cause vasoconstriction. So it seems that thromboxane A is linked to this particular type of angina.
So it also seems it's sort of a twofold effect for a heart attack is that it not only constricts the coronaries, but also increases the likelihood to clot,
Yes.
which both is pretty bad, right?
Both things you don't want.
So does that mean if I were to take a drug that inhibits thromboxane, then it would promote coronary dilation and also reduce clotting?
Definitely reduce clotting.
But not sure about the coronary dilation.
Well, I know that a person who's on aspirin, so for its therapeutics, cardioprotective, other NSAIDs are contraindicated because it negates that effect.
Okay, let's now talk about some specifics.
Last one.
Oh, okay.
So the last one is PGI2, okay, which is sometimes called prostacyclin. Okay. This one almost does the opposite of thromboxane A. So it will inhibit platelet aggregation and it will cause vasodilation.
Yeah.
And it seems to have a strong effect on the kidney's renal auto-regulation of blood flow.
Okay.
Okay, that's it
All
for
right.
me
Okay.
in all the prostaglandins. I just thought it was interesting to know what they do normally because now what we're going to do is block
Well,
them
someone needed to find it interesting.
off.
All
Okay,
right, let's move on.
you take over.
Okay, I'm going to take over because I want to talk about the fact that, so Matt's just highlighted all the different types of prostaglandins and what they can do. But the thing is that what we can look at now is that the two COX enzymes that make all these prostaglandins actually make some specifically more than others. So for example, what you would find is that, and this is the way I like to break it up, COX-1 makes prostaglandins that seem to play a really important role in maintaining gut health. Now, when I say gut health, I mainly mean maintaining gut lining. And
When you say gut, do you mean the whole GIT or, or
I'm-
the stomach only?
yeah, I mainly mean the stomach.
Okay.
So the stomach's lining inside is mucus and bicarbonate predominantly.
Why?
Why? Well, because the stomach produces acid at a pH of around about 1 to 3, which is enough to digest nails, so it's enough to digest itself. And the reason why,
Like when you chew your nails or like
No,
a
nails.
house nail?
yeah, house nail. So if you were to ingest house nails, which nobody recommends, your stomach, if it went past your esophagus, if you were lucky enough, would have the capacity to break it down. Because like I said, the hydrogen ions, H+, are between 1 to 3 pH, break it down. Okay. Now, the stomach can digest itself, but it doesn't because of two major reasons. One, a lot of mucus is being produced to create a barrier. And two, a lot of bicarbonate is produced to neutralize the hydrogen ions.
Okay.
We've spoken about it in previous episodes, but if you bind hydrogen ions to bicarbonate, it ultimately just produces water and carbon dioxide, two innocuous chemicals that we can excrete. So that's great. Now, the thing is that predominantly prostaglandins produced by COX-1 play a role in creating these two protective barriers. So that's really important. Another important point is that when you look at the thromboxane, that is going to be mediated by COX-1 as well. And so that's the pro-clotting effect. Now, if we move over to COX-2, what you're going to find is that COX-2 is important when it comes. Did you say it was prostacyclin that is the anti-clotting or the?
Yeah.
Yep. So COX-2 looks after the prostacyclin or the prostaglandins involved in stopping clotting. So I want you to think about that. COX-1, pro-clotting or pro-platelet. COX-2, anti-clotting or anti-platelet. That's important because the types of NSAIDs you give that stop these COX enzymes, if they're more 1 than 2, well, it's going to change the effect than if it's more 2 than 1. The other thing is that there's a whole bunch of prostaglandins and their effects that sit under the camp of both COX-1 and COX-2. So, for example, regardless of whether it's COX-1 or COX-2, what these prostaglandins are going to do is promote inflammation, promote pain, promote fever, and one really important thing is that it helps renal perfusion, helps bring the blood to the kidneys and allow enough blood to be filtered at the nephrons of the kidneys so that it maintains adequate glomerular filtration rate, which is 120 mils per minute. You don't want this to go too high. You don't want this to go too low. Now think about it. If it goes too low, the kidneys don't filter the blood. Metabolic compounds, products, toxins potentially build up in the blood. You get sick very quickly. So you need to maintain glomerular filtration rate, and prostaglandins help maintain glomerular filtration rate. So that means, so again, COX-1, mucus, bicarbonate in the stomach, and pro-platelet activation. COX-2, platelet inhibition. Both COX-1 and COX-2 promote pain, promote fever, promote inflammation, and help renal perfusion.
So if I was to summarize, is it best, could I say COX-1 seems to be more about homeostatic mechanisms, and COX-2 is more about inflammatory states where there's been injury, and therefore it will induce inflammation, pain, and fever.
Yeah, so, it seems, so this is interesting because there's so much overlap with COX-1 and COX-2, we know that both of them play a role in pain, fever, and inflammation. It seems COX-2 probably a little bit more so, especially when it comes to inflammation. But just know that there's significant overlap.
Okay.
I think that's an important take-home point. And the things that we highlighted that are different are the things that you should remember. Gut integrity and platelet clotting or lack of platelet clotting are the main ones.
Okay.
I think.
Okay.
Because the most common side effects, which we're going to hit shortly, will be these issues.
Right. So do you want to just put some brief NSAID drugs into these categories of COX-1 or COX-2, just so we have that starting point and then we can go into the specific drugs?
All right, that's a good idea. So let's just say that COX-1, the drug that you need to know that inhibits COX-1 and therefore inhibits the prostaglandins that have the effects of mucus bicarbonate and clotting, is aspirin.
Okay, particularly in a low dose, right?
Yeah, particularly in a low dose, but aspirin is quite commonly referred to as a COX-1 specific inhibitor.
Okay. So aspirin, if you're using it for its purpose of not clotting, so why would a person want to do that?
Well, if somebody has maybe some sort of cardiovascular risk factors, maybe if they've had some cardiovascular events in the past, maybe if they've had a heart attack in the past, as an example.
Or a high risk of one.
And
same with ischemic strokes?
Yes.
Okay.
So all these things are sort of risk factors and would basically highlight the need to maybe reduce the likelihood of clotting.
Okay.
Because it reduces your likelihood of having some sort of cardiovascular event.
All right. So is aspirin the only one that sits kind of on its own in the COX-1?
Yes, but you could also argue that something called naproxen is at low doses, COX-1 specific, but at probably over-the-counter or therapeutic doses is both COX-1 and COX-2. Seems to be more so COX-1. So it seems to be two major NSAIDs that have this antiplatelet role, and that is aspirin and naproxen.
All right, okay.
The rest inhibit both equally. Well, the rest that we're going to talk about in a sec inhibit both equally, therefore nullify any of the antiplatelet effects.
Okay, so are there any other NSAIDs that kind of do both, COX-1, COX-2?
Yeah, so ibuprofen, which you've all heard before.
That's a well-known one.
Well-known.
So that's in Australia, Nurofen, in America, Advil.
That's right, yep. Okay. And diclofenac.
Okay. So
which is Voltaren.
Voltaren. So you see that one sometimes in the Voltaren gels. So when you rub a anti-inflammatory cream, let's say you got knee pain or something, that's got that particular ingredient in it.
That's right. And so that's what we call a non-specific COX inhibitor.
Okay, as it also is ibuprofen.
Yes, but in saying that, it sort of moves over across to COX-2. So like I said, you could say that, so ibuprofen is probably the one NSAID that sits right in the middle and inhibits both COX-1 and COX-2 potentially equally. Naproxen inhibits both COX-1 and COX-2, but probably more so COX-1. and diclofenac or Voltaren inhibits both COX-1 and COX-2, but probably a little bit more so COX-2.
All right.
And then the only COX-2 inhibitor that's on the market at the moment that I'm aware of is celecoxib. So the COX-2 specific inhibitors are called coxibs,
Coxibs, yeah.
and this one is called celecoxib, also known as Celebrex.
Which is the most well-known selective 2.
Yeah, and it's one that people probably take if they've got osteoarthritis or rheumatoid arthritis.
Okay, because
But we'll get to that.
yeah, all right. So that's the most common drugs that we'll talk about now is aspirin, naproxen, ibuprofen,
Diclofenac.
good that you knew I couldn't say it, and celecoxib.
Yep.
Okay. So we know where they fit now. We know that some of them are COX-1 specific, some of them non-specific, and one is specifically COX-2.
Yes.
Now, do you want me to go into a couple of them specifically?
Yeah, let's start. Do you want to start with aspirin?
All right. What do you know about aspirin?
I know that it comes from the willow bark, and that's the end of it.
All right. So yes, it's probably one of the most common used drugs in the world. I think I did a bit of research and I found that about 80 billion tablets are used every year.
Of aspirin. 80 billion tablets.
Significantly more from its cardioprotective use rather than its pain anti-inflammatory.
Okay.
Okay. It was once referred to be at the wonder drug that works wonders.
Really?
I think
Who came up with that headline?
I think it was the company that created it, which I believe is Bayer.
Okay.
Okay, German company.
Yeah, they must have made a mint from aspirin, I assume.
Okay, so it's from a family. What family does it come from? Do you know the
Is it the Johnston family or the Franklin?
salicylates?
Oh, so you mean chemically?
Yeah.
Yeah, the salicylates.
Yes, and so
The silly sallies? No, the salicylates.
salicylates.
The silly sallies.
Salicylates.
Okay.
Yeah.
Salicylic acid, basically.
This comes from a derivative of salix, which means in Latin willow tree.
Oh, okay.
So salix means willow tree, and like you said correctly, that this drug aspirin was derived or first noted probably thousands of years ago. If people drank from a river where the willow bark or the willow tree's bark or whatever
Yeah.
went into the water, if you drank from that water, your fever would go away or your pain would disappear.
And your stomach would ulcerate.
Yeah. So Hippocrates said that this particular derivative, it was known as a bitter powder then because I didn't really know what it was,
Yeah.
would ease aches, pains, and reduce fevers.
Wow.
So it was known for a long time. But it wasn't until about 1829 that I think a German pharmacist showed that salicin is the active ingredient. Okay?
All right.
So if you take salicin in your body, it is modified to salicylic acid.
Okay.
Okay.
I don't know what salicin is, though.
Salicin is just a specific derivative of the broader, I guess, ingredient
bark?
from the willow bark. Yeah.
So if I were to take some bark and just start chewing on it, I'm taking salicin.
Salicin.
And then it turns into aspirin, basically.
No, not yet. So salicin turns into salicylic acid.
Yeah.
Okay.
Salicylic acid.
Now, salicylic acid was used for quite a long time, but it was known pretty quickly that it caused significant amount of stomach issues.
Gotcha.
And just remind me why that would be the case.
Well, because aspirin or salicylic acid is COX-1 specific in regards to its inhibition of prostaglandins, and the prostaglandins produced by COX-1 are important for maintaining gut integrity, so mucus and bicarbonate.
Yep.
Therefore, if you stop this, no more mucus, no more bicarbonate, and all you're left with is the acid to play around and wreak havoc to the walls of your stomach.
Which is a problem.
Yeah,
Now,
just a little
I think
bit.
in those days, this particular drug was used predominantly for pain and swelling, so it would have been used at a higher dose than we currently use it for platelet aggregation inhibition. So
And I don't think they had any idea as to
That's
what
all right.
was causing a heart attack.
That's right. Okay, so then we move on to Felix Hoffmann. So he was the pharmacist that his actual father was using salicylic acid
Okay.
for his own ailments, okay? But he was getting significant
Gut issues.
gut issues. Mind you, I'll just interject here and say
On yourself.
on myself. and say, I took aspirin recently and gave myself gastritis.
Yeah, what a fool.
Yeah, so I took it on an
Why
empty
would you
stomach
take
because I had a
aspirin?
headache. I had nothing else in the house. I thought I'd take an aspirin.
And it was a couple of things.
First of all, this is your favorite drug.
Wrong. It's not my favorite drug. When I get migraines, I use dissolvable aspirin.
Okay.
But I also use Voltaren or diclofenac. But firstly, used old, no
think
brand,
it was old.
no brand
It was very-
dissolvable aspirin that you just ate, and
only one, though.
on an empty stomach, and you got gastritis
Yes, all right.
for a month.
No, I got it for a couple of days.
It was pretty bad though.
It was painful. Okay, so this particular chemist known as Felix Hoffmann, employed by Friedrich Bayer and Co., so that's obviously going to be the Bayer company, his father used salicylic acid for his ailments.
Okay.
But he was getting stomach issues.
So what
he
was the
thought,
plan?
He was like, oh, we had to change this somehow. So what he thought,
What year was this? 1929, did you say?
no, this is in the 1800s.
Oh.
So he thought, I will change. In the salicylic acid, there is an acid side group.
Okay.
And he wanted to get rid of that or cover it up. So he added a acetyl group to it.
Yep.
And so it changed to acetyl salicylic acid or ACA. Okay. And this basically was the start of aspirin.
All right.
Okay. So this is now essentially aspirin. Okay.
So we're at aspirin.
So I was going to have a point. Well, it's important just to note here that when you when you take in drugs that are derived from salicylic acid, such as aspirin, they're actually acid forming. So they actually, when they're metabolized in your body, they actually put you into a metabolic acidotic state
In the blood.
in the blood. But it's also not to say you'll get metabolic acidosis, but it will put you into a state of producing hydrogen ions.
Which your body counteracts quite quickly.
But also, it's a local acid. So if you take these drugs, on an empty stomach, it's irritating,
Gotcha. So it's directly irritating.
directly physically irritating.
Okay, because this is an important point, which I always...
And that's why I say things like aspirin sometimes have enteric coating,
Yes.
so they're not dissolved in the stomach.
Well, a couple of things. So everyone's probably heard of, when you're taking an NSAID like ibuprofen or aspirin, take it with food. And they say this because they say, well, you got to take it with food because it helps soften the blow of the drug on your stomach. And my thought would be, well, the peak time in
Acid
which...
anyway, right?
Well, yeah, and the peak time that your stomach... peak time in which this drug, the serum levels are at its highest, it's like an hour afterwards. Your stomach, potentially, if you've just had a banana, is going to have squirted that all through to your duodenum by then. So I never understood why people would say, take it with food. However, it seems to be that it really does soften the blow and reduce the gastric effects. But it also seems to lower the absorption rate as well.
All right, so we're currently in 1897 and we now have acetyl salicylic acid.
We're going to go year by year, guys.
Okay. So Bayer didn't really use it for a couple of years, and it wasn't until the head scientist at Bayer decided to release it. This was in 1899, but they didn't. The way they decided on the name is they didn't extract it from willow bark, okay, because willow bark's not the only place you can get it from. You can get it from other flowers. So they used to derive it.
That's going to go through every flower now that you can get aspirin from.
They derived it from a particular flower that they call meadowsweet, which is spiraea, and that's where the word aspirin comes from. Spiraea or spirine, aspirin. Okay?
Wow.
So then aspirin was now used, and
How's that fact, everyone? Are you going to keep that fact in your head
Well, I
and
like
tell
it.
your friends?
now it wasn't until the 1970s that we found out actually how aspirin worked.
Really?
So the person was John Vane. He got a Nobel Prize. So he discovered in 1970 how
So was this the first person to identify COX?
Probably. Yeah. And so he figured it out in 1970s, got the Nobel Prize in 1982, and was knighted afterwards.
Wow.
So then we know exactly how it works. So that's aspirin.
Yep.
Primarily, as we said, it's a very successful drug for blocking platelet aggregation.
Yeah, so aspirin inhibits COX-1 specifically. COX-1 is important to create prostaglandins that produce gut mucus, gut bicarbonate, and also platelets. So if you take aspirin, it stops gut mucus, stops bicarbonate, but also stops clotting, especially at the lower levels or lower concentrations, and hence why this is used for cardioprotective strategies.
Okay. Are there any side effects of note that you want to talk about here?
Well, we've pretty much already brought it up, but GIT bleeding is probably the biggest one. Ulceration, bleeding, especially in people who are already at risk. So it's often you'll find that if people are on aspirin long term, they're probably also going to be given PPIs or proton pump inhibitors as well, as to protect the stomach. So basically, if you're not going to produce the mucus, well, let's not produce the acid either.
Right, okay. I think it's also contraindicated with children under 12 because they can develop something called Ray's syndrome, which is to do with blood flow, I believe.
Yeah, I forgot about that.
And also there are some people, and you're going to probably counteract this, but there's some people that seem to have an aspirin allergy, which can cause like asthma-like symptoms.
Yeah.
So that's well known, but didn't you say?
Yeah, so it's mainly the discussion between whether aspirin and ibuprofen have an effect, or is it paracetamol and ibuprofen? Are you sure it's aspirin?
Aspirin's a big one because it's aspirin-induced asthma.
Yeah, so I know that the evidence for ibuprofen-induced asthma is a bit squirrely at the moment. So I would just say if somebody has a history of asthma, and they want to take an NSAID, that it's best to consult your GP because they'll be able to tell you the best medication, pain relief medication or anti-inflammatory to take if somebody is an asthmatic, such as a child.
All right, so that's aspirin. Do you think we've covered everything we need to in aspirin?
Yep, I think we should move on to naproxen. What do you reckon?
All right, you take over.
I take over.
I'll come back and do paracetamol.
Okay. So, naproxen is both a COX-1 and COX-2 inhibitor, but probably a little bit more so a COX-1 inhibitor. So what that means is naproxen is going to have similar effects to that of aspirin, which means it does have a bit of a platelet blocking effect, but also can have its effect on the gut too, so stopping mucus and so forth. It's not salicylic acid like aspirin. It's propionic acid. Or propionic acid. And propionic actually means first acid because it's actually one of the smallest fatty acids that they've been able to produce. And the propionic acid, just out of interest, Matt's going to give his stupid facts, I'll give one of mine, is that propionic acid is the reason why we have body odor and why cheese smells is because of this particular chemical. It's actually the chemical that makes up naproxen. Now, naproxen, you've probably heard of it. It's got a lot of trade names, but one of which is naprogesic. Have you heard of naprogesic before? I think naprogesic was more of an older school NSAID. But anyway, an important point because naproxen sits closer to COX-1, even though it's both COX-1 and COX-2. It actually has the smallest overall cardiovascular risks of all the NSAIDs.
So less cardiovascular toxicity, yeah.
Exactly right. So apart from that, that's all I've really got on naproxen. Obviously, it plays a great role with stopping pain, stopping fever, and stopping inflammation, and also has that slight cardioprotective effect.
Okay. Oh, what about ibuprofen? Got anything there?
All right, so ibuprofen is both COX-1 and COX-2. Doesn't seem to be one so more than another like the other ones. Low dose, it seems to be, equal as beneficial as aspirin and paracetamol. Are we going to talk about paracetamol today?
Yeah, I'll do that next.
Okay. It can be used to help close, like Matt was saying, the ductus arteriosus. It's one of the ways they do this. It seems to be quite good at improving things like gouty arthritis or even osteoarthritis or rheumatoid arthritis. We're going to talk about the coxibs shortly, like celecoxib. And you probably heard that the coxibs are used specifically for joint-associated pain.
But why is that?
Okay, so because the evidence was that they thought that it stopped specifically prostaglandins that were produced in joints. But this just isn't the case. So the evidence now shows that ibuprofen, for example, and more so Voltaren, is just as beneficial, if not more beneficial, to treating arthritis-associated pain than celecoxib.
Yeah, my understanding, and I could be wrong here, but my understanding of why they went into the coxibs was people who were using NSAIDs for joint pain, so the arthritis. So this could be rheumatoid and osteoarthritis. These are chronic states, so they need to be taken at long term, right?
Yeah.
And so these NSAID drugs that you mentioned, like ibuprofen and naproxen,
Yep.
are great. They work, but you really can't take them for more than 2 weeks.
Because of the gut issues, right?
Or got gut issues, kidney issues, cardiovascular potential issues. So particularly if you have patients who are cardiovascular risk, or they've got renal insufficiencies, or gut.
Yeah.
So they work, but they cause complications.
So so that's a good point. So let me rephrase my statement then by saying that in a group that are not within a cardiovascular risk factor group, so an average population, there's no benefit of taking celecoxib over ibuprofen, for example, or Voltaren, in regards to its ability to mitigate that inflammatory-based pain.
Yep.
However, celecoxib is more expensive, so it's probably not cost-effective to be celecoxib. But if it is a group that is also prone to gut issues, then it probably would be moving over to celecoxib. However, like I said, we've now got really great ways of counteracting the gut-associated effects of NSAIDs, like PPIs, for example, proton pump inhibitors. So it seems to be that if somebody takes a long-term NSAID with PPIs at a appropriate dose, it's potentially fine.
Yeah, and I think it's also that you can take some of these drugs in conjunction with prostaglandin promoters. So
Seems counterintuitive.
yeah,
doesn't it?
but apparently you can counteract the stomach effects by putting more of the, I forget which one of the PGEs wouldn't have more of a function in the stomach.
Okay.
So there is that possibility as well.
Yeah.
All right.
I thought another important point here is that so I just want to compare ibuprofen to aspirin, just briefly. So what the studies have shown is that if you want to stop some inflammation-based pain, that ibuprofen is going to be far better than that of aspirin. So studies basically showed that if the amount of aspirin you would require to have an equivalent anti-inflammatory effect as ibuprofen to stop some sort of joint-associated pain over a 72-hour period would be around about 4 grams of aspirin. And so that's in the toxic doses. So basically, I think Matt said it, the only thing that aspirin's probably good for at the moment is cardioprotective. I mean, there's so many other drug options that are better than aspirin when it comes to pain, inflammation, and fever.
And probably the doses that you would take for just the cardioprotective would probably not cause you a great deal of issues to your stomach.
All right.
All right, paracetamol, also known as?
Acetaminophen.
Acetaminophen,
yeah.
So I'm going to call it
Matt's terrible at pronouncing words. He can't even say my name half the time.
Okay, so that's true, actually. I always spell it with a H.
Yeah, Heichel.
All right, so paracetamol kind of came off the back of aspirin as well. So
we didn't talk about side effects of ibuprofen.
I thought you did it. Okay, let's do it.
Okay, so side effects of ibuprofen. Again, you can have gut issues because there is overlap with these things. So they just say take with food. By no means as bad as aspirin or even naproxen. But one of the big issues, especially with abuse of ibuprofen, is that of kidney disease or acute kidney insufficiency or acute kidney disease, right? And so this is due to the fact that you're stopping the prostaglandins at the kidneys. And I don't know if we said it, but the prostaglandins at the kidneys dilate the afferent arteriole of the blood flow coming into the nephron. What does all this mean? Well, the blood in the body needs to be filtered. Like I said before, 120 mils per minute. And the diameter of the blood vessel coming in plays a big role on how much blood is getting filtered. prostaglandins dilate this blood vessel so that more blood comes in to get filtered. If you take NSAIDs like ibuprofen, it can stop these prostaglandins, constrict that afferent arteriole, reducing how much blood's getting perfused, and therefore this can result in acute kidney injury. You okay with that?
Yeah. So would this be applicable to everyone or more so for patients who are vulnerable with their kidney functions already vulnerable?
All about doses, but everyone, but obviously a vulnerable population needs to have this conversation with their medical provider.
Okay. All right.
Okay, sorry. So you want acetaminophen?
I think also just to add one point, which I did allude to earlier, that ibuprofen is probably going to be contraindicated or heavily considered not to be used in conjunction with your aspirin because it will negate the effects that the aspirin will do.
Yeah, good point.
It will counteract the cardioprotective effects by probably inducing a platelet aggregation. Okay, so probably through the other, not the thromboxane, but the other one. What was that? Prostacyclin. But also it seems to have an effect to vasoconstrict the coronaries as well.
Okay,
so
not good.
That's a problem.
That's the opposite of what you really want to happen when you're taking low-dose aspirin.
Yes. So that's just something to be mindful of. And I believe, I think that's all really.
So why are we talking about acetaminophen now? It's not an NSAID, right?
No, because an NSAID would assume that it's an anti-inflammatory.
It's in the name.
Yeah.
But so if you were to put it in there, you would say it's a non-steroidal drug.
It's
but it doesn't mitigate inflammation. But
it's good for pain.
What about fever?
It's good for fever.
Okay,
but not for inflammation.
Gotcha. So it is anti-pyretic and is also analgesic.
Yes,
but not anti-inflammatory.
Correct.
Gotcha.
But we don't completely know how it works.
What do you mean?
Well, we know it.
You don't?
Well, definitely I don't. I did a reasonable amount of research on it, and a lot of studies have they're not conclusive.
So I was under the impression that it does work on the same pathway. It just doesn't act upon the prostaglandins involved in inflammation. That was my impression.
Yeah. So you'd be probably correct there because they've found that certain effects, like when we spoke about the ductus arteriosus, if a mother was taking paracetamol, that it would actually then close it.
So paracetamol and acetaminophen are the same thing, right?
Yes.
Okay.
So
and Tylenol.
Tylenol would be the American name.
But it has the same effect as ibuprofen in closing the ductus arteriosus.
Yeah, so it then would demonstrate that it has some effect on the COX enzymes.
Okay.
Yeah. But again, not sure.
But not anti-inflammatory.
Not anti-inflammatory.
So if you have inflammatory-based pain,
you wouldn't take paracetamol.
No.
Acetaminophen. Yeah.
Okay. That's good to know.
Yeah.
And what about toxicity?
It seems to also...
Does it have renal toxicity like the others?
Not as much. There is metabolites that are produced by the breakdown in the liver of paracetamol.
So all of these NSAIDs break down in the liver, we should say.
Yeah, they have very good absorption capacity. Their bioavailability is pretty good, but the way that they're metabolized is all different.
Yeah, a lot of them are lipophilic.
So paracetamol, I'm going to do a bit of history again. Michael rolls his eyes. Okay, so 1884. Again, we're in Germany. The Germans did very well in that time in their pharmaceutical area. Okay, and I think it's also Bayer-related.
Good on them.
I think it's also Bayer-related here as well. So in 1884, there were two doctors that were reporting to Adolf Kussmaul. Okay? Kussmaul. And I assume...
Like Kussmaul breathing?
Yeah, that's what I'm assuming. I'm assuming it's the same physician that came up with that Kussmaul.
Maybe he gave them enough opioids that it resulted in depression of respiration. Or maybe Kussmaul breathing is associated with... Oh, no, I'm thinking Cheyne-Stokes breathing.
DKA.
Yeah, Kussmaul's DKA.
Rapid breathing.
Yeah.
Maybe he made them hyperventilate.
Maybe he gave them so much salicylic acid that they did become acidotic and they were breathing like that. And hence the Kussmaul breathing.
There you go.
There's the link, guys.
Brilliant. So
We've cracked the case.
These practicing doctors came up to Dr. Kussmaul and said, look, we've got a patient with a worm infection.
They would have said this in German, I would assume. Can you do it live?
Guten Tag.
Accent.
Guten Tag. That's about as far as I got.
Mein Doctor. Keep going.
So there's a worm infestation with our patient. We need to somehow rectify this. And so Dr. Kussmaul said, look, I have this intestinal antiseptic known as naphthalene. Naphthalene.
You would have thought he would have practiced this before we started.
He said, take this drug and give it to the patient, and it should cleanse their worm infestation.
What is this drug?
Naphthalene. Naphthalene.
All right, I'm gonna have a look and read it.
Okay. Moving on. So they gave this drug to this patient. It didn't seem to have any effects with the worm infestation
So he was wrong.
and any effect on the ailments that are associated with the worm infestation.
So why did he say that?
Well, let me get to it.
Okay.
But what they did notice is the patient's fever disappeared. And so they were like, this is strange. So they went back. They wanted to explore this particular drug's effect on fever. So they went back to the pharmacy and said, hey, you gave us this drug. It didn't seem to work for the intestinal worms, but it knocked out his fever. And then the pharmacist said, oh, I actually gave you the wrong drug. I gave you acetonolide. Okay? Acetonolide.
Okay.
Okay? So it has the similar start as acetaminophen. Okay? So acetonolide. Okay? So it wasn't actually gave the drug that they were intended to give.
So this poor bloke had worms, and they gave him Panadol.
The wrong drug. The wrong drug. Acetonolide. That's right. So then they wanted to explore this acetonolide. So the same doctors went and gave this drug to a whole lot of rabbits and dogs
Right.
in the laboratory, not just out in the street.
All right.
Okay. They found that it worked. It was successful in
As what?
In reducing the fever of the rabbits and dogs. Okay.
How they induce fever in rabbits and dogs?
Good question. I didn't find that in the paper.
Infection, maybe?
Yeah. I guess they would have had it somehow inducing a reaction like that. But it did reduce the fever in those particular species. Then they brought them into their patients. So that they then trialed it on 24 patients.
Yeah.
And they found that it worked great. So they gave the drug the name antifibrin. Basically,
Febrile.
that's right. But the only side effect is they saw that the patient went blue.
Okay.
Okay. So basically this drug...
Just that small side effect.
Basically this
Is it
drug...
cyanotic?
not cyanotic, but it was hemotoxic. So it caused a state called methemoglobinemia.
I've heard of that.
Okay, so and I think this is where paracetamol can be toxic to other animals like dogs and cats. I think it puts them in this hemotoxic state. I could be wrong, but that's what I did read into, that it induces methemoglobinemia.
Okay.
Globinemia. Okay. So
what's that mean? It just means
they
it
wanted to
pushes the oxygen off the hemoglobin.
and they added another group to it.
Competitively binds.
So they wanted to look at alternatives to this acetonolide.
Yeah.
Okay, because it's now shown to be toxic. Great for fevers, but toxic.
But bad for life.
Yeah. So Bayer, this is in the 1930s, looked into slight derivatives of that, and they came up with phenocynidin. Okay, phenocetitin.
So
These are hard names.
Do you think
these are
that
hard
you've
names.
mispronounced every drug so far?
Possibly. Now, this drug, this slight derivative, showed a lot of promise. It did basically everything that the last drug did, but it started to knock off people's kidneys. Okay? But
Jesus.
it was effective. Okay?
At what? Like killing them?
At both doing the fever side of things, but also the analgesic side of
Okay,
things.
good news. You don't have a fever.
But-
Bad news, kidneys are gone.
But in long-term use, it was shown to be detrimental to the kidneys. And the way that they figured this out was, particularly there was a cohort of people, for some reason, in Switzerland. Now, in Switzerland, which I'm not sure was Switzerland then, was Switzerland or was it part of Germany?
I don't know why you're asking me.
Anyway, so For some reason, there was a cohort of workers in Switzerland that were working on watches, in the manufacture of watches. There was a big industry in those times. And because the construction of watches required a lot of focus and probably eye
Hand-eye coordination,
acuity
dexterity.
and so forth, it caused a lot of headaches on the job.
Okay.
And so there was a certain amount of drugs they called just headache pills, which
Yep.
this cohort of workers just went wild with.
All right.
And so there was three
Watchmaker's gone wild.
there were three ingredients in these headache pills. There was the phenacetin, which we spoke about, aspirin, and caffeine.
Oh,
Now, caffeine can be useful in headache type pain.
vasodilator.
I think they're vasodilator or vasoconstrictors. I'm not sure which. One
I
of the-
think, well, you want to do one or the other because what causes a migraine is the rapid changing of one to another. So it doesn't matter if it constricts, doesn't matter really if it dilates, but you just don't want it to constrict, dilate.
Yeah, so these pills were used for these particular workers quite successfully. They were actually great for headaches.
Cool.
But these cohort of people
We're urinating blood.
were overusing them.
Yep.
And for some reason, what started to pop up in that part of Switzerland was a type of kidney disease called interstitial nephritis, which would be probably the combination of the aspirin, the effect of the aspirin, and the phenacetin.
Right.
Okay. Now, the phenacetin is the one we were talking about. We've already spoken about aspirin. So they finally realized that the phenacetin is the molecule they have to modify. And this is,
To make acetaminophen.
that's right, to make the paracetamol. So it wasn't then until the 1946.
All right, so we're in 1946.
We've kind of moved quite a lot now, where US scientists looked and found that
It seems like we're going through the dates in real time.
that when the body metabolized phenacetin, it actually made it into paracetamol, which is not
Wow.
paracetamol, it's the chemical equivalent to it.
Paracetamol's trade name, isn't it?
That's right.
So
Or
acetaminophen.
the generic name.
Yeah.
But the chemical name, I don't know, it's probably N-acetyl
Yeah.
something of NFL.
Yeah, something like that.
So
So we're done with...
Almost.
Okay.
So now we're left with paracetamol. This is where I'm going to end. Paracetamol generally is a very well tolerated analgesic drug. Okay, in its therapeutic dose, it doesn't generally cause
Very safe.
Yeah, it's very safe. However, in high amounts, it's extremely hepatotoxic.
Okay, so we've
Okay.
spoken about nephrotoxic, but now hepatotoxic.
So when you take a paracetamol and it's well tolerated in your GIT, unlike the aspirins, so it's not going to necessarily cause physical effects. It's well absorbed. When it gets to your liver, because remember all blood from the GIT has to go through your liver first for first pass metabolism, it's metabolized in three ways. The biggest way, about 40 to 67% of it is processed by your liver, adding a glucose group to it, which is a glucuronide. Okay? It's a sugar group which makes it water soluble. You can pee it out.
Yeah.
Another group adds a sulfur group to it, and that's about 20% to 30% of metabolism is in this way. Okay? As a side point here, children under the age of 2, this is the only way they can metabolize paracetamol,
Is what way?
is through adding the sulfur group. Their liver hasn't matured enough to be able to add the sugar group. So when you give paracetamol to children, you have to be extra cautious because their metabolizing ability is much lower than an adult would be.
Okay.
So I think in pediatrics, it's about 15 milligrams per kilo. That's the way they kind of work it out.
For children.
For children, yes. Now, the final point is, or the final way it's metabolized is through that 5 to 15% of it's metabolized through N-acetyl P-benzoquinolamine, or NAPQ.
Okay.
This is extremely hepatotoxic.
Ooh.
Extremely.
All right.
So when a person ingests more than 4 grams of paracetamol, these toxic metabolites will build up in your liver
Yeah.
and kill your hepatocytes off.
Wow.
And you will essentially go into acute liver failure.
They're only produced when you take a lot, or they're
lot.
always produced? It's just that once you hit a certain quantity,
Correct.
it's too much to deal
Correct.
with.
And so if you're now looking at a toxicity point of clinical practice, the physician, if a person overdosed on paracetamol or acetaminophen, the doctor or the physician has about 8 hours to work with.
Otherwise, your liver's gone.
To give the anecdote. Anecdote.
So you got to tell them. You got to tell them the story.
Tell them the story. Yeah, so you can give a drug called NAC. It's obviously the acronym. I don't know what the chemical is.
Okay.
It blocks this particular metabolite building up and causing its hepatotoxic effect. But you've got about 8 hours to work. That's the window to work in.
Wow.
Okay? Now, if you miss that window, the liver will go into complete shutdown and you'll probably go into multi-organ failure.
It's called N-acetylcysteine.
Okay.
That's the antidote.
Not the anecdote.
Not the anecdote. The antidote is N-acetylcysteine, NAC.
Now, the NAPQ, which is the toxic metabolite, that is also nephrotoxic.
Okay.
In enough quantity that will knock your kidney off as well.
So take-home point is Panadol or Tylenol. No.
Yeah, Tylenol.
In the States, or basically acetaminophen, is quite safe at the therapeutic doses, but going over can be damaging to your liver and potentially irreversibly damaging.
Yeah. Once you've got to the hepatotoxic level, there's no going back. And so the biggest cause of acute liver failure in at least younger persons, probably in the Western world, is paracetamol overdose.
Wow, that's
And
horrendous.
I think at least in Australia, 13,000 consultations with the poisoning centres in Australia is due to paracetamol overdose.
Really?
Yeah.
My
So
God.
it's by far the largest cause of, it's not prescriptive, pharmacological based overdoses in Australia. But
Wow.
I'd assume that is in all the Western world.
I didn't know that.
Yes, so significant.
All right,
But it's a well-tolerated drug, and in its therapeutic phases or its therapeutic uses, it's very safe. But it's a drug that's used in many other drugs. So it can be used in cold and flus. It can be used in hybrid medications like put in with codeines. So you've got to be careful. It could probably be even used in syrups. Like
yeah.
cough syrups or
So
certain
try not
things
to
like that. So you got to
take too much.
You got to be sure what you're ingesting, because you might be using a bit of Tylenol here or Panadol here, but then you might be using it for something else, and then you might have an overdose case.
Yeah, good point.
All right, so that's it for paracetamol.
Yep.
Sorry for my pronunciation on all those
Of everything.
long chemicals, but they're
Let's
tough
finish
words.
with the last two NSAIDs, which are diclofenac and celecoxib.
All right.
So we'll be quick because diclofenac, which is Voltaren, I'm just going to say Voltaren because it's far easier, even though that's its commercial name. It's both COX-1 and COX-2. However, it does push over towards COX-2, and therefore, if it pushes over towards COX-2, it may play more of a role in inhibition of platelet inhibition, so pro-clotting, which means that there are some studies out at the moment looking at whether Voltaren, or I shouldn't say Voltaren specifically, but diclofenac is pro-clotting and can increase likelihood of cardiovascular events. Currently, it says probably not, but it's still being evaluated at the moment.
It's interesting because it's one of the only drugs that seem to be associated with topical use. So it seems to go with use in patches and
we know
gels. Yeah, I'm not sure. But it's interesting to see why that might be the case, whether it has a greater side effect profile or maybe it's easier to be absorbed topically. I'm not sure.
It seems to be probably one of the best anti-inflammatories of all the NSAIDs, is diclofenac, and that's probably because it's both COX-1, COX-2, but a little bit more COX-2, because a lot of the inflammatory prostaglandins seems to sit more under the COX-2 banner. When we look at the last one, and did you want to add anything else to diclofenac?
No, I don't even really know much about it.
Okay. So
And I can't pronounce it, so I'm not going to go there.
Look, I'm probably pronouncing it incorrectly too, because why say it when you can just say Voltaren? It's probably the most common one out, at least in Australia. Now, when we look at the COXIBs, so this is interesting. COXIB is a COX-2 specific inhibitor. And like I said, COX-2 inhibits platelets. So if you inhibit this inhibitor, it's pro-clotting. Now, this is important because the old school coxibs, one of which, for example, is called rofecoxib or I think it's rofecoxib, which was under
Now
the name.
who's got the problem?
I know, under the name Vioxx. It had shown, a number of studies showed that
Because I think Vioxx and Celebrex came out at similar times, right?
similar times. And so they did a number of studies comparing the two, but also comparing it to other NSAIDs and comparing it to placebos, and found that in patients who were at an average risk for GI bleeding, that one, coxibs probably aren't cost effective. They're very expensive. And so we know now that if you're comparing coxibs to like ibuprofen, probably ibuprofen is maybe, definitely cheaper. Yes, it increases your likelihood of GIT upset. So if you're at a risk, in a risk category, probably not worth taking, but again, discuss with the GP. Coxibs came out because they do protect the stomach. I shouldn't say they protect, they just don't have the problematic effects of the stomach side
But
effects.
also for long use.
For longer use, but they also do potentially increase likelihood for clotting. So what I was saying was that some studies showed that it increased the likelihood of clotting. I think it was up to, there was a fourfold. So they compared rofecoxib, which was one of the old coxibs, with
Vioxx.
with naproxen. And we spoke about naproxen being COX-1 and COX-2, but a little bit more COX-1 inhibition. Compared those two, and they found that rofecoxib had a fourfold increase in myocardial infarctions over a 9-month period of taking it.
Did you get the number? It was something.
No.
It was something like 13,000 over its 5-year use.
Of
Something like
MIs or deaths or?
MIs,
Wow. So
which resulted in something like 40 to 60% deaths
Wow.
from those MIs.
No,
so
I
it was,
didn't
it
read
was
that.
significant.
So, but this fourfold increase in MIs was only found in the cardiovascular risk group. So it wasn't an increased risk in a non-cardiovascular risk group, which means maybe if the average person's taking rofecoxib, it's not going to increase your likelihood of having an MI, for example. However, more studies came out and they showed, it doesn't seem to be too safe. The fact that it increases your likelihood of clotting isn't a great thing. They had a look at celecoxib, and currently the evidence for celecoxib is that it doesn't seem to increase the likelihood for clotting.
Yeah, and that was a relatively recent study, a New England paper, journal
of medicine.
Yeah.
And that's the.
But I guess the take-home message from us, we're not clinicians. We're trying to give you the basic science of how these things work and read the studies on what's presented to us.
Yeah.
The best thing you can do in this space, if you're unsure, is talk to your physician.
Yeah,
and ask these questions.
None of this is advice. Please recognize that. We are just highlighting the evidence. And if you do take NSAIDs and you want more information, talk to your GP. If you want to change medication, talk to your GP. Remember, just because it's over the counter doesn't mean it doesn't have drastic side effects. So it's always important to discuss with your physician exactly what drugs you are taking because, and this is where I think we want to finish it, there are a number of contraindications of taking NSAIDs with other drugs. So just think about it. You probably, if you're a budding health professional, you probably know already from what we've said other drugs could be that have this effect. So for example, think about the fact that you are taking something that increases your ability to potentially clot. Or let's think about aspirin, decreases your ability to clot. What if you're on warfarin, which decreases your coagulation? You don't want to take warfarin with something that also decreases your ability to clot because it's going to increase your likelihood to bleed and bleed outs.
Yep.
So that's a contraindication. Aspirin with warfarin, for example. Lithium is another one. Did you know that?
No.
So it seems to, the NSAIDs in its entirety seem to increase lithium serum levels to a point that may be damaging to the nervous system. So make sure you, again, talk to a GP if you're on lithium and you want to take some NSAIDs. Methotrexate.
So that would be for rheumatoid arthritis?
Yep. High doses of methotrexate seems to be poorly tolerated with NSAIDs. And here's the big one, antihypertensives.
Yes. So NSAIDs can raise blood pressure,
Yes.
probably through a combination of vascular alterations, but also kidney autoregulation.
Yeah.
And so in this case, if you're a person that's taking blood pressure medication, particularly the Prils or the Sartans, the interaction could be quite profound. And so this is something that you would have to look into. So, or even the diuretics. So I think the three that go together that can cause significant problems to your kidneys would be diuretics, ACE inhibitors or angiotensin II blockers, and NSAIDs.
Beta blockers.
Yeah. So that's something that has to be.
But calcium channel antagonists don't seem to have an effect with NSAIDs, which sort of highlights that it may all be mediated at the kidneys.
So
Renal or extrarenal.
Yeah. All right.
We done?
Should we do a quick run through, or are you happy with?
Okay, this is the take-home message. Prostaglandins promote pain, inflammation, and fever. We want to stop them, so we stop their production through inhibition of COX enzymes, COX-1, COX-2. There are drugs that we can take called non-steroidal anti-inflammatory drugs, or NSAIDs, that inhibit either COX-1 or COX-2 or both. COX-1 specific, aspirin; COX-2 specific, celecoxib; COX-1 and COX-2 non-specific, naproxen, ibuprofen, and diclofenac. COX-1 plays a role in mucus gut lining and protection, but also pro-clotting. Type 2 plays a role in anti-clotting. Therefore, if you inhibit one or the other, you're going to have the opposing effects, which is important. Generally speaking, if these drugs are abused or not used properly, it can result in kidney disorders. Acetaminophen, more so with hepatic disorders, but these NSAIDs can be associated with hepatic disorders as well.
And also with acetaminophen, it seems to have more centrally COX effects. So the effects of blocking COX enzymes in the CNS, which is probably the analgesic effect.
Yeah.
With the cannabinoid effect as well.
Yeah. And so all of these drugs, if they need to be taken, should be taken in the appropriate dose range or therapeutic range. And if people want to take these drugs and they're already on medication, they should discuss with their GP whether there's any contraindications or drug-to-drug interactions.
Yeah, and refer to the instructions at the back of the box, because that will also tell you certain situations to be aware of.
And the most important thing is you should follow me on Instagram at Dr. Mike Todorovich, at DrMikeTodorovic, or you can contact us on Twitter. I'm at Mikey Todd.
Yep.
And at Dr. Bartox. All right, guys. Or just go onto Facebook, Dr. Matt and Dr. Mike's Medical Podcast. Watch our YouTube channel.